Hello and welcome, everyone. My name is Kristen Talbot. I'm the Program Manager of MAVEN Project, and I welcome you to today's session, Hypertension Update 2024, a session from the partnership with MAVEN Project and Direct Relief. It is my pleasure to introduce today's speaker, Dr. Charles Schulman. Dr. Schulman is a senior physician emeritus who recently retired from active practice after 53 years, but continues to teach and consult. In addition, he has been practicing non-invasive cardiology since 1970. Dr. Schulman's scientific articles and abstracts have appeared in the New England Journal of Medicine, Circulation, the American Journal of Cardiology, and the British Heart Journal. And we're just very thankful to have Dr. Schulman as one of our volunteer speakers. So Dr. Schulman, when you're ready, please begin.
Okay, well, thank you very much, Kristen, and thank you everybody else, and good morning to those of you who are somewhere between Boston and the California coast. Today's talk will be on hypertension and some of the updates and concepts that are worth reviewing. This is my disclosure is that I have no conflicts of interest, nor does anybody else who has anything to do with this conference. The MAVEN Project, as you're aware, is accredited to provide CME credits and designate this for an hour of Category 1 credit. And with that, we'll start with an item of history going back to the 1930s and 1940s, at which time President Franklin Delano Roosevelt was very busy trying to get the country out of the Depression and to wage World War II after Pearl Harbor. And these are some of his blood pressures that were known at that time. At age 55, he was noted to have systolic hypertension. By 1941, his blood pressure was 188/105. 2 years later, it was 210/160. 210 to 260/112 to 150. And in 1944, it was recorded as high as his systolic pressures were recorded as high as 240 and 260, at which time he developed congestive heart failure, for which he was treated with digitalis, which was the only thing available at the time. On April 13th, 1945, he suffered a cerebral hemorrhage, which the physicians thought, quote, came out of a clear sky. There was no indication of imminent danger. We know better than that today, and there's a lot we can do about it. So the learning objectives of this talk are to review proper technique when measuring blood pressure, to talk about blood pressure goals, and to implement a strategy for both initial and subsequent both non-pharmacologic and pharmacologic management, and when to look for secondary drivers. Hypertension, as I'm sure you're all aware, is a pervasive problem. It's estimated that 122 million adults in the United States have blood pressures that are greater than 130/80. 3 out of 4 of them have uncontrolled hypertension, and hypertension is the primary cause of 124,580 deaths in the United States as of the last time those figures are available. In addition, the costs are incredibly expensive. The prevalence of hypertension increases with age. As you see here, between the ages of 55 and 64, 65% of people have hypertension, 65 to 74, 73 to 75% have it, and over the age of 75, more than 80% have it. But even at young ages, there are significant numbers of people with hypertension, so it should be treated at any age. This is an old meta-analysis of studies published in 2002, so it's 22 years old. 61 studies involving more than 1 million adults, looking at the risk of ischemic heart disease mortality and blood pressure. Here are increasing blood pressures. Here is increasing risk. And you notice that there are a series of curves depending on age. So age and blood pressure both have an importance. This is systolic pressure, this is diastolic pressure, and the risk of cardiovascular death doubles for every 20/10 millimeters of mercury increase over starting at 115/75. More recent data confirms that cardiovascular mortality, stroke, coronary heart disease, and myocardial infarction all increase in prevalence when you go from normal blood pressures to elevated blood pressures to hypertension. Now, I'm going to show you two studies. This one is a landmark study that was really a game changer that reported in 2015 and is the basis for the 2017 guidelines. This is the SPRINT trial, an NIH trial of over 9,000 people, 35% of whom were female, 28% of whom were over the age of 75, and 30% of whom were African Americans. The primary outcome was a composite of myocardial infarction, acute coronary syndrome, stroke, heart failure, or death from cardiovascular disease. And people were randomized, 4,600 people in each group were randomized to treatment which was thought to be standard at the time, which was a goal blood systolic pressure of under 140, and an intensive group with a goal blood pressure of under 120. Achieved levels were 136 and 121. And these are some of the results. There was a 25% statistically significant difference in the primary outcome, but also in all-cause mortality when you compare the intensive group to the standard group. And those differences were even greater in older people, as you can see here. There were adverse events of course, there are adverse events in any study, and the ones of particular interest were hypotension and injurious falls in the older age group. This is a more recent study. This is what's called the STEP trial. 8,500 Chinese patients between the ages of 60 and 80. Randomized to what was called standard treatment, systolic pressure 130 to 150, versus intensive treatment, systolic pressure 110 to 130. And what you can see here is that the cumulative incidence of the primary outcome events was reduced by 26%, statistically significant. So this confirms the SPRINT trial results in older people. One thing I found interesting as I put this together was that blood pressure lowering can result in reducing the risk of new onset type 2 diabetes. Okay, this comes from the blood pressure lowering treatment trialist collaboration, the same one that I previously showed you, published in 2000, the original results published in 2002. And regardless of body mass index, the risk of type 2 diabetes was lower in the treatment groups as opposed to the comparator groups. That was especially true for angiotensin converting enzyme inhibitor-based treatment, angiotensin receptor blockade type treatment, but not for beta blockers. Three questions to ask when your patient comes in, and you should probably ask it before you measure the blood pressure as opposed to during. Were you rushing to get here or physically active right before this appointment? Have you been taking your medicine? And what's your diet and physical activity regimen like? And so we turn to taking the blood pressure. What is wrong with this picture? What are some common mistakes that are shown in this picture? Somebody wants to put an answer in the chat. We'd be happy to consider it. Legs crossed, right? Feet should be flat on the floor, no coffee, talking. You guys are right on. And here is the here's the proper way to do it. So sit in a chair, back supported, legs not crossed, feet on the ground. Empty your bladder before having your blood pressure taken. Don't drink coffee during. The blood pressure cuff should be applied to a bare arm, and you shouldn't be talking. Tell you a funny story about that. My significant other went to her primary, saw a new primary care physician to check her blood pressure. And while he was taking her blood pressure, he was telling her about how when he went home to Ecuador, he had to carry a gun and take a security detail with him because it was so dangerous. At a time when we were planning a trip to the Galapagos Islands off of Ecuador. Naturally, her blood pressure was much higher than it ought to be. Now, this is as a result of SPRINT and other studies. This is the 2017 guideline. Previously, there was the JNC, the Joint National Committee for the Prevention, Detection, Evaluation, and Management of High Blood Pressure. But that committee published its last formal report in 2003. That was JNC 7. There was an attempt at an updated, but it never really made it. And so by 2017, the American College of Cardiology and American Heart Association took over the task of developing guidelines for hypertension and also for other cardiovascular conditions. Normal blood pressure has always been under 120/80. So that's always been normal. In the previous guideline, between 120 and 140 was considered pre-hypertension, and over 140 was considered hypertension. That's now been changed so that between 120 and 130 is considered elevated blood pressure, and stage 1 hypertension begins at 130/80. Right? So the definition of high blood pressure is a blood pressure of greater than 130/80. Now, salt intake is important in hypertension. High sodium dietary intake raises blood pressure, and limiting salt intake lowers blood pressure by reducing extracellular fluid volume. The mean sodium intake in the United States, when it's been measured, has been somewhere between 2,300 and 4,700 milligrams of sodium per day. And so, in trying to reduce sodium, we have a few questions, okay, in terms of foods and how people can try to reduce their salt intake. Okay, so here we go. Which has more sodium? One Hebrew National Beef Frank or 11.5 ounces of V8 juice? Put your answers in the chat. Okay, we have somebody has accused me of asking a trick question. The answer is if the V8 juice. A Frank has 480 milligrams of sodium. The vegetable juice has 920 milligrams of sodium. Which has more sodium? One Panera Bread Southwest Caesar salad with chicken, or one slice of large, well, probably one large slice of Domino's Ultimate Pepperoni Pizza? Put your answer in the chat. Ha 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 ha. Okay, so we have a mixed response. Some people think it's the pizza, some people think it's the salad, and the answer is the salad. But the salad has 1,070 milligrams of sodium, whereas the pizza only has 830 milligrams of sodium. So this is half of what we'd like people to ingest for the entire day. Next, last one. Which has more sodium? One Chipotle burrito with rice, beans, plant-based protein, salsa, guacamole, cheese, and sour cream, or one Olive Garden chicken marsala fettuccine entree? We have, again, various answers. And the correct answer is the burrito. Now, look at the quantities. The burrito has 2,860 milligrams of sodium. The pasta has only 300 milligrams less than that. And this is more than what we'd like you to have. You know, a low salt diet would be about 2,000 milligrams or 1,800 milligrams. So you can see how dangerous, if I can use that term, this is. The American Heart Association has labeled the salty six: bread and rolls, pizza, sandwiches, cold cuts and cured meats, soup, especially canned soup, burritos, and tacos. So, you know, lowering salt intake can lower blood pressure in pre-hypertension or in hypertension, African American or non-African American, or even resistant hypertension. So you can get a lot of quote mileage end quote out of salt restriction. And here the salt restriction was to 1,800 milligrams per day. Here it was 2,300. Okay, what are some strategies for sodium reduction? Read food labels and buy low sodium versions of food. Stick with fresh foods. That's better than frozen foods. That's better than canned foods. Canned foods have the most salt, as you'll find if you start reading labels. And cook without salt. For those of you that serve patient populations that use adobo seasoning has sodium in it. There are low sodium adobo seasonings available. Now, turning to the role of aldosterone in hypertension. Aldosterone leads to sodium retention, volume expansion, the upregulation of angiotensin II receptors, and the potentiation of the depressor responses to angiotensin II. Again, leading to extracellular fluid volume expansion and hypertension. One clue to hyperaldosteronism is potassium, a low normal or a low potassium despite a potassium sparing agent or potassium supplements. Although you can have hyperaldosteronism with a normal serum potassium, so don't depend on that. But low potassium is a clue. This emphasizes that we should treat hypertension early. This is a follow-up study of 25,000 children versus matched controls whose mean age was 11, who were found to have hypertension, whose mean age was 11. And those who had hypertension over the years had more major adverse cardiac events. That's what MACE is, major adverse cardiac events. So that 28 years later, we're talking about 11 plus 28 makes 39. So that, before the age of 40, we're looking at people who are having adverse events. The point being that you should treat hypertension early as you find it. Now, there are in hypertension there are conditions that are called or have been traditionally called end organ damage. Probably a better terminology is hypertensive cardiovascular disease. And there are some early markers of hypertensive cardiovascular disease that we can recognize, and when we recognize them, we should treat the hypertension more vigorously. One is an exaggerated blood pressure response to exercise. So somebody that gets on the treadmill for a stress test, whose blood pressure is greater than 210 in men and greater than 190 in women, has a hypertensive response to exercise. And even if their resting blood pressure is normal, this is an abnormality and should be carefully followed. The second one is the loss of the nocturnal dip, reduction in blood pressure during the night when you're supposed to be asleep. Okay, the British call it the nocturnal dip, and it relates to the circadian variation in hemodynamics and catecholamine levels. So that during the day those are high and they fall when we go to sleep, and they're lowest in a person. This is in a person who wakes up at 7 in the morning and goes to sleep at 10 or 11 at night. They're lowest at 3 to 5 in the morning. Okay, so there's this dip. And in a meta-analysis, a blunted heart blood pressure decline was associated with increased adverse events. So here's nocturnal blood pressures in someone that doesn't experience the nocturnal dip, or whose blood pressure doesn't fall at night. This might be true of somebody who has sleep apnea, who never really has a good night's sleep. And this leads to hypertension and to adverse events. Cardiac markers of hypertensive cardiovascular disease include left ventricular hypertrophy, either on ECG or on echo, reduced diastolic relaxation, that is diastolic dysfunction, and coronary artery calcium. Coronary artery calcium is a sign of coronary artery disease. The only way you can get calcium in your coronary arteries is to have coronary artery disease, which would, in this case, be a result of hypertension. Vascular marker would be increased carotid endomedial thickness, And renal markers would be microalbuminuria, increased serum creatinine, and a reduced GFR, and then retinal artery changes. Now, these are non-pharmacologic interventions for the prevention and treatment of hypertension, and some of the approximate impacts of those treatments on systolic blood pressure. So for every kilogram of weight reduction, you can anticipate a millimeter of mercury blood pressure reduction. The DASH diet, dietary pattern, which is a diet rich in fruits, veggies, and is low fat, a reduction in dietary sodium, an increase in dietary potassium, increasing physical activity. One of my favorite topics to emphasize is people should exercise. Moderation of alcohol consumption. If you ingest 3 drinks a day, it's much more difficult to control blood pressure, or whether you're a man or a woman. And it's been shown now that people who have sleep apnea, who wear their CPAP for more than 4 hours a night, have a reduction in their nocturnal blood pressures and in their overall blood pressures. These are other aspects of weight loss, or other treatments for weight loss, I should say, besides diet. This is a follow-up, 5-year follow-up of bariatric surgery compared with people whose obesity was treated with medical therapy. And at the end of 5 years, where the people who had the bariatric surgery lost a mean of 55 pounds, almost half of them were on no hypertension medicines at the end of the 5 years, as opposed to only 2.4% of the patients treated with medical therapy. So bariatric surgery is, I guess, one way of treating hypertension in an obese individual. Another treatment would be one of the newer agents, tirzepatide, one of the GLP-1 receptor agonists, and it's been shown to lower blood pressures as well. Here are the most recent physical activity guidelines as issued by the Surgeon General's office in 2018, 5 years ago or 6 years ago now. Move more and sit less, right? One of the Heart Association's mottos is move more. Any amount of physical activity has health benefits. Everything counts. So emphasize that to people, because they think that if they're not going out and jogging, or going out and playing tennis or pickleball or whatever, that they're not exercising. But in fact, if they're walking, they're exercising. And again, everything counts. The goal is 30 minutes 5 times a week of at least moderate physical activity. The goal would be reached with more vigorous physical activity, such as running or vigorous bicycling. Physical activity helps prevent 8 types of cancer, reduces the risk of dementia and all-cause mortality, reduces heart disease, stroke, high blood pressure, type 2 diabetes, and depression, and improves bone health, physical function, and quality of life. In addition to all of that, for older adults, physical activity also lowers the risk of falls and injuries from falls. You know, people say they don't want to exercise because they're afraid of falling, but if they're accustomed to exercising, they're going to fall less, not more. And any exercise training mode will improve blood pressure. So this is aerobic exercise. This is resistance exercise. This is a combined regimen. In my opinion, a combined regimen is the best regimen of dynamic exercise, or what's referred to as cardio, and weight training. And I write the exercise prescription. So here's the exercise prescription. You know, frequency, intensity, and duration. Frequency at least 3 times a week. Intensity at least moderately hard or brisk but comfortable, right? You should know you're exercising. And duration between 30 and 45 minutes with warm up and cool down before and after the exercise session. Now, here are the pharmacologic treatment guidelines and thresholds for adults with high blood pressure. And that's divided into people at low risk and people at high risk. For people at low risk, blood pressures between 120 and 129 emphasize heart-healthy lifestyle. For blood pressures between 130 and 139, intensify the lifestyle modification and start medication at blood pressure of 140/90. On the other hand, if the risk is higher, 10-year risk of greater than 10% according to the ACC, AHA risk calculator, or the new Heart Association Prevent calculator, or diabetes or chronic kidney disease, with blood pressures that are lower than 130, emphasize heart-healthy lifestyle, but begin pharmacologic treatment at 130/80. Okay, 10 millimeters of mercury less than for the people with low risk. The treatment target is 130/80. A number of findings, have come out since the 2017 guidelines, and these are some of them. This is not all of them, but these are some of them. Out of office blood pressure readings are recommended. Home blood pressure is the most practical method to document blood pressure for medication titration. If you're using telemedicine or telehealth, and the patient is taking and recording his home blood pressure, you don't need to physically see him unless you want to actually take his off his blood pressure. During the pandemic, I did that for over a year. I depended on people to take their own blood pressures and report them to me. People with difficult to control or resistant hypertension should be screened for primary aldosteronism, for primary aldosteronism. I already pointed out that young people with hypertension have an earlier onset of cardiovascular events, so don't delay treatment. Lifestyle modification not only prevents hypertension, it improves the effectiveness of pharmacologic therapy. Intensive blood pressure control is not associated with increased hospitalization, nor does it increase the risk of orthostatic hypotension. And orthostatic hypotension, which is asymptomatic, is not associated with higher rates of events or syncope or falls or renal failure. For older adults with hypertension, intensive blood pressure lowering may, or at least partially, arrest cognitive decline. And a multi-level, multi-component implementation strategy, including team-based care, is the most effective method of blood pressure control in hypertension. So when you're thinking about pharmacologic treatment, drug treatment, please know that the major determinant of cardiovascular risk reduction is the amount of blood pressure reduction and the blood pressure which is achieved, not the choice of drugs. In the olden days, which means after the JNC7, from 2002 onward, and when ACE inhibitors and ARBs were developed, all of the drug companies that manufactured these drugs were trying to prove that their drug was better than all of the other drugs. And it turns out that it doesn't really matter which drug you choose as your first line agent and base your blood pressure regimen on it. This is a 23-year follow-up of the ALLHAT trial, which was the original basis for the 2003 JNC 7 guidelines. 32,800 people, and you see that no matter what the blood pressure drug is, that the results are the same. Okay, now there are some exceptions to that, as you know, as everything else. A study showed that benazepril and amlodipine led to fewer cardiovascular events than benazepril hydrochlorothiazide. And then there are people with comorbid conditions who have non-blood pressure indications for medicines like ACE inhibitors or ARBs for heart failure or diabetes, AV nodal drugs for AFib, and spironolactone for heart failure with preserved ejection fraction. You'll get a decent blood pressure response in, a third to a half of patients from any class of drugs. And if you try a different class of drugs, you'll get about the same response. So the algorithm would go something like this. If the systolic pressure is greater than 20 millimeters of mercury and the diastolic pressure is greater than 10 millimeters of mercury over the goal, which would be 140 over 90, if it is, start low doses of 2 drugs. If not, and the patient is not spilling a lot of protein in his urine, start 1 drug, which could be either an ACE inhibitor, an ARB, a dihydropyridine calcium, or a dihydropyridine calcium channel blocking agent. If there is proteinuria, an ACE inhibitor or an ARB would be your first choice. If the blood pressure remains uncontrolled, either switch or add the second one. If it remains uncontrolled, add a thiazide-like diuretic. Reassess after 2 to 4 weeks. In other words, don't have the patient come back in 3 months. Have the patient come back in a month. You'll get. I don't know if the MAC. Whatever benefit you're going to get from a given treatment will be evident by the end of a month. Avoid therapeutic inertia. That is, patient comes in, his blood pressure is too high, nothing changes. So do something, right? Just do it. Combination therapy is more effective than the max, than pushing 1 dose to the max. And the most common causes of the lack of response are the medication non-adherence, white coat effect, and improper blood pressure measurement. This just shows head-to-head trials with indapamide or chlorthalidone versus hydrochlorothiazide. They're better blood pressure lowering drugs. There's some controversy about whether they actually lead to fewer cardiovascular events. Now, these are recommendations for diabetics. This comes from the American Diabetes Association guideline or standards of diabetes care in January 2024, and the diabetes folks suggest that we treat people starting at a blood pressure of 130 over 80. If the blood pressure is between that and 150 over 90, start 1 agent. If there, depending on whether there's albuminuria or coronary artery disease. If not, start 1 drug. If there is, start an ACE or an ARB. If the blood pressure is higher, start 2 agents. similar to the other algorithm that I showed you. The treatment targets for diabetics with hypertension. The diabetes guidelines recommend an individualized approach. They were previously recommending a blood pressure of 130/80 only, or in higher risk patients, but they changed that so that the latest recommendation is for a goal blood pressure of under 130/80 for everyone. And then, of course, if the treatment is tolerated and the target is achieved, continue therapy. If you're not meeting the target, either add an agent from a complementary drug class. If there are adverse effects, consider switching. If you're still not meeting your target and you've already added a diuretic, consider the addition of a mineralocorticoid receptor antagonist, spironolactone, or eplerenone. The difference between spironolactone and eplerenone is that eplerenone does not have gynecomastia as a side effect. Now, there are secondary drivers of hypertension, which include chronic kidney disease, sleep apnea, and medications, especially non-steroidal anti-inflammatory agents. And these are one of the worst culprits because people take them and don't tell you. Now if someone twists his ankle and takes ibuprofen for 2 days, that's not going to lead to a permanent blood pressure elevation. But if your patient is taking non-steroidals, ibuprofen or any of the others, every day, that certainly could elevate his blood pressure. ADHD meds, other stimulants are other culprits. I mentioned sleep apnea. And we should emphasize primary hyperaldosteronism. Think about it in patients who have severe or resistant hypertension, patients who have hypokalemia, patients who have sleep apnea, and patients who have unexplained atrial fibrillation. Now, that leads us to the definition of resistant hypertension. So what is resistant hypertension? Well, it's a blood pressure that's high despite 3 or more drugs. Okay, but before you make the diagnosis of resistant hypertension, exclude these conditions. Exclude secondary hypertension caused by drugs or other diseases. Exclude pseudo-resistance due to medication non-adherence or poor blood pressure technique. Masked hypertension is high blood pressure at home and a normal or close to normal blood pressure in the clinic. White coat hypertension is the opposite. It's high blood pressure in the clinic and normal blood pressure at home. Okay, so here's the management approach to resistant hypertension. Exclude other causes. Ensure a low sodium diet. Maximize lifestyle interventions, okay, including sleep, overall dietary plan, weight loss, exercise, and then optimize your 3-drug regimen. So make sure that they're taking drugs of different classes, renin-angiotensin blocker, calcium channel blocker, and a diuretic at maximum or close to maximum tolerated doses. If the blood pressure is still not a target, consider changing hydrochlorothiazide to chlorthalidone or indapamide. Blood pressure is still not a target, add spironolactone or eplerenone. Still not a target, at that point, think about adding a beta blocker, especially if the heart rate is high. Still not a target, add hydralazine. Finally, minoxidil. Now, here's a situation that I've been asked about. This was a consultation sent to me through the MAVEN Project. 53-year-old asymptomatic African, well, he was really Caribbean American man with hypertension and type 2 diabetes. He came here from the Bahamas and was seen in a clinic in Florida as a new patient. His history is that he has hypertension and type 2 diabetes. This is his blood pressure regimen, but he hadn't taken his medicines for 2 months since he came to the United States. He had an A1C of 10.2, so his diabetes was out of control, which he has been treating with diet and weight loss on his own. His blood pressure at that clinic visit was 226 over 135. His exam was otherwise entirely normal, and he had no symptoms. So, what should you do? Send him to the ER because he has a hypertensive emergency. Order an ECG and basic labs. Order an echo looking for left ventricular hypertrophy. Order a nuclear stress test. Take 2 Valium and call me in the morning. That's a variation of an old joke. Take 2 aspirin and call me in the morning, and restart his meds and follow up in 2 weeks. What do you think? Okay. Agrees with Cindy. Okay. Restart meds, follow up in 2 weeks. Okay, so you guys are on the ball. This is not a hypertensive emergency. That's part of the point. A hypertensive emergency would be blood pressure in that range, but with one or more of the following: hypertensive encephalopathy, an intracerebral hemorrhage, acute ischemic stroke, an acute MI, acute left ventricular failure, unstable angina pectoris, dissecting aneurysm, acute renal failure, or eclampsia. So he doesn't need to go to the emergency room. We used to call this hypertensive urgency. I'm not sure it's an urgency. It's more like uncontrolled blood pressure. Yes, he should have an ECG and basic labs. Yes, he should have an echo looking for left ventricular hypertrophy if one hasn't already been done. A stress test has no place here because he doesn't have any chest pain. And so my answer is restart his meds and follow up in 2 weeks to see how he's doing. So my approach to blood pressure goals involves some of the following. Don't let controversies about blood pressure goals keep you from initiating treatment. In other words, if you're not sure you go along with a blood pressure of 130 over 80 as the goal, but the patient's blood pressure is 160 over 90, treat him anyway. You need to get his blood pressure, his or her blood pressure down. Don't let the patient tell you, quote, "I've always had high blood pressure." Well, they can tell you, and you can agree that they've always had high blood pressure, but it should be, your job should be to try to lower it. I use a stepwise approach. Aim for a systolic pressure of 140. If you can do that without adverse effects, aim for 130. Again, small doses of 2 drugs may be more effective than pushing 1 dose to its max, and don't let therapeutic inertia keep you from changing or up-titrating medicines. And, there are things we can do to improve adherence, because that's a major problem for hypertension, for heart failure, for conditions in in specialties, in many areas. Educate and counsel patients using motivational interviewing techniques. Simplify medical regimens. Use fix dose combinations where you can. Encourage self-monitoring of home blood pressure, get buy-in from the patient. Intensify treatment in the setting of suboptimal adherence. Use 90-day prescription refills instead of 30 days. That helps. And use a multidisciplinary team-based care approach. Involve everybody in your clinic, including doctors, nurse practitioners, nurses, medical assistants, and pharmacists if you have one available to you, and utilize telehealth strategies where that will be beneficial. I like to end with this. This is a talk that Roger Blumenthal gave about primary prevention of cardiovascular disease, and this is his sort of quick and easy summary of blood pressure for primary prevention of cardiovascular events. 120 is the new 140. Lifestyle modifications first, last, and always. For high-risk people, add medicines at 130 over 80. For low-risk people, add medicines at 140 over 90. And finally, we have the doctor telling the patient that in order to prevent a heart attack, take an aspirin every day. Take it out for a run, take it to the gym, and then take it for a bike ride. Thank you very much. And we have
We
time
have
for
lots of questions, Dr. Schulman.
Oh, okay. Are they all in the chat?
There's one in the chat. Most are in the Q&A box, but I'm gonna read the one first from the chat just so I don't lose it. Is there a drug treatment regime that is better for older patients with orthostatic hypotension?
Not really. Although I think the diuretics may be problematic in older people because they don't maintain they don't maintain minimal hydration, right? You want to reduce total body fluid volume, but you don't want to have them dehydrated. So, but there's no specific regimen, and I think you just have to be careful about that. I had one patient who was really a terrible example of or a terrible dilemma, really. Her blood pressure was 160 to 180 lying down, and 115 sitting up. It's very difficult to add medicines in that setting because you're going to make her, make her postural hypotension much worse. Okay, next question.
What do we do with patients who have high B blood pressure, or just high blood pressure in the morning before taking their hypertension meds, but after taking them is normal for the rest of the day?
I would keep if it's normal for the rest of the day. What really counts is the average blood pressure over 24 hours. Or the average or the mean of blood pressure over 24 hours. So if your average blood pressure for the entire day is low, then I would not, especially after you take your medicines in the morning, then I wouldn't, I would just continue the medical regimen.
Who do we test for high aldosterone, and how is the test ordered and done?
Well, there are a number of places where you can a number of things which should stimulate you to look for hyperaldosteronism. People who have difficult to control blood pressure, people who have true resistant hypertension, we're not, we're talking about a patient with resistant hypertension, not a resistant patient with hypertension. So, those kinds of conditions, and low potassium would be another place to look. You'd measure aldosterone and renin levels on early morning specimens, and look for the ratio, look for elevated aldosterone. Or you can just add, if you have a patient with not controlled hypertension, add aldosterone, add spironolactone and see what happens. You may get very prominent blood pressure lowering, despite 3 or more previous blood pressure meds, in which case, if the blood pressure comes down with spironolactone, you can consider, reducing or stopping one or more of the other drugs.
How important is heritable component to the diagnosis and management of blood pressure?
Basically not. That is to say, if you have a strong family history of hypertension, that's not the goal. That's not going to change the treatment thresholds. It's not going to change, and it's not going to change the goals. What it may change, and not a family history of hypertension, but a family history of premature coronary disease, may change your risk for coronary artery disease, which would increase the need for good blood pressure management.
If we start 2 medications and there is a side effect like a rash, we wouldn't know which one caused it. Do you ever separate starting 2 meds out, and then when 2 meds are indicated to start patient on per the algorithm?
I've always, you raise a good point. I have usually not started 2 at the same time. I usually start 1 at a time. I have over the years. And the reason is just that if the patient develops a rash or something, then you know what caused the rash. Prescribing 2 medicines at the same time, the medicines can be separated by a month. That's not going to lead to any adverse, that month is not going to lead to any adverse effects in and of itself. So if you're uncomfortable starting with 2 medicines, the guidelines all say, the European guidelines, the American guidelines all say start a combination therapy. As I say, if you start 1 and wait 2 weeks and start this, add the second one, that's not going to make a big difference in the long. Not having the 2 medicines for those 2 to 4 weeks is not going to make a difference.
Okay. When adding aldactone for resistant hypertension, do you stop thiazide, diuretic, or continue?
I don't stop the thiazide when adding spironolactone, not aldac. Yeah, well, it's aldactone, right? Aldactone is the trade name. No, I don't stop it. It would depend. It would depend on, what else is going on, but no, I wouldn't stop it.
All right, so we are at time. So Dr. Schulman, thank you so much for another great session, and thank you all for joining us today.
Okay, thank you. Thank you, everybody.
Have a great weekend.
Have a great weekend.